Good evening, friends. So a little different type of a webinar today. Research articles. We know that across the world, tremendous research keeps on happening, which many of us may not be looking up. So one is a research article. Second is financial advice and need of financial literacy for doctors. This topic has been identified almost 30 years ago by various associations, GP Association of Greater Bombay, IMA. That's why there are social security schemes, because we know that we don't understand money. So this is a glimpse of what we should know. Blood pressure. These are from American Heart Association. Classification of blood pressure is normal, systolic 119 or below, diastolic 79 or below. There is no lower limit as long as patient is not symptomatic. So many patients may come to you and say, I have a low BP. You have to explain to them there's nothing like low BP. Low BP only occurs in cardiovascular shock when the patient needs to be in ICU and will require the support of noradrenaline and similar drugs, inotropic drugs. Why the patient tells you I have low BP? That patient may have gone to a doctor sometimes and complained that I feel giddy, and the doctor checks BP, or I have a headache and it is lower reading, lower side of normalcy. The doctor labels the patient as low BP. Now we have to understand here cause-effect relationship. My clinic is right on the main road. So anybody meeting with an accident or anybody collapsing on the bus stop would be rushed to my clinic. So once upon a time, we had a accident on the road and one fellow was standing at the bus stop. Looking at all the blood, he had a vasovagal attack. He was brought to the clinic. The BP was 80/60. That was not the cause of him collapsing. That was the effect of him collapsing. So I told him, although your current reading is low, but because you collapsed, you don't have low BP. Pre-hypertension, 120 systolic to 139 systolic, and diastolic 80 to 89. In normal, both of these have to be present, and in other three stages, any one of these. So I may have a systolic of 120 or 119 and a diastolic of 88. That patient is pre-hypertension. Stage 1 hypertension, systolic 140 to 159, diastolic 90 to 99. And stage 2, systolic 160 or above, and diastolic 100 or above. American Heart Association in clinic BP measurement guidelines. These guidelines have been researched. So I divided into two columns. What are the recommendations of American Heart Association? And does it happen in our clinic? Do we follow that? Patient should be seated comfortably with back supported, legs uncrossed, and upper arm bared. Does this happen? At least not in my clinic. Patient's arm should be supported at heart level. So you need a staff in the clinic to support the arm at heart level, or a relative. I don't do that. Cuff bladder, not the entire cuff of cloth, the bladder inside, which gets inflated, should encircle 80% or more of patient's arm circumference. How many of us have multiple cuffs? 99% will have only one cuff, and we try to make do with the same cuff. Mercury column should be deflated at 2 to 3 millimeter per second. So if you raised it to 180, to bring it down to 80, from 180 to 80, that's 100 mm, that is 50 seconds. Do you have that kind of time? Or do you actually follow this? The first and last audible sound should be recorded as systolic and diastolic, respectively. Yes, we all do that. Measurement should be given to nearest 2 millimeter of mercury. Neither the patient nor the person taking the measurement should talk during the procedure, but we generally keep talking because we have less time per patient, and I want to be sure that I make use of all the time. So we are generally talking with the patient. So nothing happens. The patient should not talk during the procedure because this may cause deviation in the measurement. We agree. Patient should not talk even when you are auscultating. Other factors that can affect the measurement include exercise, smoking, alcohol consumption, muscle tension, bladder distension, room temperature, and background noise. So alcohol, okay, nobody will consume alcohol and come to clinic, but there may be people who just finish a cigarette just outside your clinic. And if one day you are sitting idle, this patient may come rushed and you take BP immediately without the requisite relaxation, you get a wrong reading. In older patient, blood pressure should be measured routinely in the standing and seating position to screen for postural hypertension, or as I would say, standing and lying down position. This is, please take a snapshot, cuff sizes as per American Heart Association. So if the patient's arm circumference is such, you should have cuff sizes. It doesn't say it should not cover more than 80%, but it should cover at least 80%. What does the new research say? Should clinic BP be routinely measured lying down? Taking a patient's blood pressure when the patient is lying down or in a supine position yields much more result, much more information about their cardiovascular risk, the likelihood of them getting a myocardial infarction, a stroke, or a fatal cardiac event, than taking the reading when the patient is sitting upright. Anyway, you just saw that all of us are not following. Okay, wait a minute. I am very sorry. I did not show the slides and I didn't see anybody writing. So I'll start again. I don't mind. Starting from scratch. I have said all this, so I will rush fast, but then I will go through every slide again. Normal blood pressure, 119 or lower than that, and 79 or below. This both have to be of this level for us to say it is normotensive. Pre-hypertension, systolic 120 to 139, or diastolic 80 to 89 is pre-hypertension. Stage 1 hypertension is systolic 140 to 159 or diastolic 90 to 99. Stage 2 hypertension, systolic 160 or higher, diastolic 100 or higher. So if I have a patient who has a systolic blood pressure of 130 and a diastolic of 102, that patient would be stage 2. I have done all this, but I'll still show you. Patient should be seated comfortably with back supported, legs uncrossed and upper arm bared. I don't do this. How many of you do this? Keep in your mind. Patient's arm should be supported at heart level. You need one more person, either patient's relative or your assistant. Cuff bladder, not the entire cuff of the cloth, the bladder that gets inflated, should encircle 80% or more of patient's arm circumference. Mercury column should be deflated at 2 to 3 millimeter per second. There's no this thing of inflation, it's deflation. The first and last audible sound should be recorded as systolic and diastolic. We all do that. Measurement should be given to nearest 2 millimeter mercury. And neither the patient nor the person taking blood pressure should be talking during the procedure. The patient should not talk during the procedure because this may cause deviation in the measurement. Other factors that can affect measurement include exercise, people having come after a brisk walk. A lot of patients take an evening walk and go to the doctor for BP check. You should refrain from checking that time. Smoking, muscle tension. See, if you check yourself, especially in electronic machines, when you are checking your biceps relaxed and the BP is 130 by 80, you just tense your biceps, not even majorly contract, just tense. The BP will jump up by 15 to 20 millimeters. In older patients, you should check standing and sitting or standing and lying down to pick up postural hypertension. More so if there is a history of patient complaining of dizziness on standing up, and if the patient is on clonidine, because that is one drug that very commonly gives postural hypertension. The cuff size, please take a snapshot. So the new research says, should BP be routinely measured lying down? The research, which is after 25 plus years of observation, says that BP checked in supine position or patient lying down gives you more information about the cardiovascular risk of the patient, likelihood of coronary artery disease, myocardial infarction, stroke, or a fatal cardiac event, and you can take precautions in treating or in investigation. Analysis of data from a long running, the study was atherosclerosis risk in communities, ARC. More than 11,000 adults showed those who had hypertension while supine, lying down, were at elevated risk for cardiovascular disease, independent of their having hypertension while seated or not. Even if they don't have high BP while sitting, and if they have only on lying down, they still have a greater risk of cardiovascular events. If blood pressure is only measured when the patient is sitting upright, while people are seated upright, cardiovascular disease risk may be missed if not measured also while they are in supine. Of course, we don't have that much time. So I will say if you are measuring only one time or one type, measure supine. Hypertension while asleep, again repeating, strongly associated with cardiovascular and death, but whether hypertension detected in clinic while the patient is lying flat is a risk factor for CVD independently. The patient's BP while seated remains unclear till now. That is still being researched. Hypertension while asleep, when the patient is sleeping. Just one second. We know that most of the heart attacks occur early morning when the patients are sleeping. But lying flat diagnosis, whether that also increases how much risk death we're talking, that is still being researched. And when it comes out, I will share with you. Data now, how this study started, atherosclerosis risk study. In 1987 to 89, patients who did first consultation were monitored. Both seated and supine hypertension were defined as systolic BP of more than 130 or diastolic more than 80. The data revealed that 16% of those with no hypertension when seated had only supine hypertension. So 84% had supine, 16 had only sitting, and 74% of those with seated hypertension also had supine hypertension. Despite adjusting for seated hypertension, now the study started in 87 to 89, a median follow-up of 25 to 28 years. Supine hypertension was associated with an increased risk for incident coronary heart disease, heart failure, stroke, and fatal CHD, cardiac arrest, and all-cause mortality. The result did not differ by antihypertensive medication usage. For patients who had hypertension while supine, but not while sitting, elevation in the risk were similar to those who had hypertension both seated and supine. These findings then suggest the conclusion of the researcher was people with known risk factors for heart disease, hypertension, diabetes, dyslipidemia, morbid obesity, OSA, and stroke benefit from having their blood pressure checked while lying flat on their backs. Every patient of ours above 35 is at a high risk for hypertension, so we might as well check them lying flat. And these findings also indicate that sustained control of BP in all body positions is important. I cannot say sitting is normal, lying down is more. No, I have to control that lying down one also. In busy clinical practice, it is impossible to do both seated and supine, as well as standing. Hence, only supine recommended. Where there is a history or a suspicion of postural hypertension, you can do supine and standing. But when you do supine and standing, please remove the cuff from patient's arm. Let the patient stand, maybe give half a minute, and then tie the cuff again, and then check. Making the patient stand up with the cuff still there does not give you a true reading. Then many patients say we can't come to you regularly. So even for home monitoring, what I tell patient is whichever machine you have, there is a product insert with the machine. You follow all the steps required as a prerequisite. What happens in families if one person is checking on dining table, everybody else says, okay, check mine, check mine, check mine. That is not the right way to check BP. Strictly follow the prerequisite of that product. And the first thing is 10 minutes of rest without any physical activity and lying down flat or sitting with arm on the table supported. 10 minutes of relaxation and supine position. Another study said, earlier we used to say that 3 readings at least should be taken before you label somebody as a known hypertension and consider treatment, either drug treatment or lifestyle management. But now home BP monitoring is also being accepted. The US study showed that 3 days or less of home BP monitoring is enough to diagnose or rule out high BP. But with all the instruction followed, nothing in a haste, different times of the day. After first day of monitoring, 63.7% could be confidently identified as having high blood pressure or normal blood pressure. Of course, you don't start treatment with one day reading only. After second day of monitoring, another 17.1% could be confidently identified as having high BP, that is around 80%. After third day, another 10.5% would be confidently identified. So you are able to identify 90% of patients. If you are a popular doctor, you have patients from far and wide, then they can't come to you every day for BP checkup. So you have to trust them. And if it is possible, what we do in our clinic, we calibrate our machines every 6 months. So if a patient buys a machine, electronic, we check it with our machine whether it is equal or not, or approximately equal or not. This is so much about BP. Some questions are there. Let me take. Which apparatus is more reliable, digital dial or mercury? Actually, mercury is the most reliable. But then now WHO has said that there is a chance of mercury poisoning. So they have said electronic is better. I just purchased a machine from Diamond, which is reading is just like mercury, but it is electronic. The column of light goes up. It runs on electricity or battery. Yes, all electronic machines are accurate. Okay, I'm sorry for the earlier damage of no slides. Coming to money, and whatever I'm going to talk now, please ask yourself, is it true or is it not? Practicing medicos and finance knowledge. Few facts. Although many may not like it, those of you who are in a service, every other doctor is earning on everyday basis. I won't like to say daily wage laborer, but then we have daily wages. And again, not sure how much we'll make today. From pre-medical days till today, whatever our age, we are only thinking of medicine, CME, and practice. Large chunk of our practice is cash. So ideally, we should have good amount of savings. But how many of us, how many of you actually have very good long-term savings or investments? Many of you will agree with me, those who are senior. Around 30 years ago, one medical association realized that two of the senior members who had lucrative practice, always packed, they suddenly died. In one family, wife didn't have money for funeral expenses. Other family, wife had no money to pay for the child's education fees. And both of them didn't know where the husband had kept money. Both were sudden cardiac deaths. We have no concept of budget. People who are in private practice, because we earn every day. If you work in 2 shifts, you earn in 2 shifts. And then you spend like that. Possibility of being cheated. We thrive on trust of our patients. So we tend to trust our patients a lot. Many of the doctors have got cheated by investing cash with their patients on interest basis, and the patient vanishes. Then why we are talking now? Because everybody has felt that practice is going down. It happened in COVID era because clinics were shut down. In sickness, if you are sick and you are absent from practice, you go on a long holiday and you remain absent from practice. All the money that we spend nowadays is accountable money, because very little we spend on cash. Everything is e-commerce or UPI, is all accountable. And whatever inflation occurs, our fees do not rise in the same proportion. What they don't teach us in medical college. This is a survey again from America. Physicians who have taken a hit to their income. In India, a lot of doctors shut down practice because the premises were on rental. They couldn't afford to pay the rent. And everybody noticed that income has dropped. So the doctors are looking at ways to reduce unnecessary expenses, because increasing practice is not in our hands. Every morning you go, you don't know how many patients you will see today and how much money you will make. Close to 3/4 of physicians said they have not done any major changes, but they are still worried about their financial future. Those who are young are worried of buying houses, getting married, having family. Those who are 50 plus are worried of retirement. Our duties may change from professional. In the clinic, I'm a professional. At home, I'm a personal, my personal expenses. But how we approach our money, that should not and does not change. So there is so much that we can do to control our money. If we had a fixed income, no, we'll learn how to control money, because that money has to last for 30 days, including any emergency expenses. So some useful strategies, something I picked up from the research, something of my own. Pay attention to the big picture. Step back and look at all the aspects of money you spend from a functional. If you have a practice, how much money you spend in your practice to run your practice. If you have a job, how much money you spend to go to your job and deliver the duty. We need a budget philosophy. If we are salaried, yes, there is a budget. But if we are private practice, there is no budget. Any money that we spend should only be for a specific necessary purpose. I have been guilty of this splurging. You practice in the morning and you have some few thousands in your pocket. You go to a book exhibition, you don't mind emptying your pocket. You may not even read those books because you're going to make money again in the evening. There are three things which we are not aware of, but we should gradually learn: a balance sheet, an income statement, and cash flow statement. I'm not going to bore you with knowledge, financial knowledge. All I'm saying is, I want to give you an insight. Am I aware this much about my practice? Balance sheet is a summary of financial balances, assets and liabilities. What you have in your clinic, if you have stock of medicines and injections and dressing material of 1,10,000, that is your asset. And if you have to pay the bills of 62,000, that's your liability. In the house, if you have a television which is paid for, so that's an asset. If you have a television for which you are paying EMIs, or your house for which you are paying EMIs, that's an asset, but then asset only becomes possible because you have a liability. Income statement: your earnings, your expenses during a particular period. Do you calculate every day, every week, how much money you made this week and how much money you spent? And cash flow statement: I need cash in my hand. You know, some 15, 20 years back, most drug wholesalers boycotted supplying to the doctors directly from pharma companies because they said doctors don't pay on time. To get a bill of few hundred, I have to send my man twice or thrice. They just stopped because we are like that. We may have money stashed somewhere, but we don't have cash in hand. And if we have, then we don't want to pay. Cash flow statement summarizes the amount of cash and cash equivalent, UPI, checks, and other things, entering and leaving your practice or personal life. These statements must be studied monthly at a minimum. And we need to understand what each line item represents on these reports. It will take time. Ask ourselves, if I'm spending a particular amount of money, how does it impact my patient care? Am I able to deliver better care or not? And is it necessary for my patient and my staff in the clinic, or am I just wasting money? We should understand each of the processes. If I'm doing a blood sugar, am I doing a costing? What is my cost of doing a blood sugar on a glucometer and how much I'm charging? What is the cost required to make my patient care much better and ensure that my patient is satisfied? This strategy can stabilize practice, spending, and improve our profits because we all need to make profits. Easiest way, I think I will not go this because this goes little more in accounts. Every expenditure, if you are married, discuss with your spouse. And if you're not married, then discuss with someone you trust and do it frequently because we always think we are thinking right. Take a honest snapshot of financial position every quarter and limit big expenditure, which are more than 10, 20, 30,000 as per your budget, and discuss with that person. Admit what you don't know. This is a honesty check. Do you know what is the cost to see each patient? How will you arrive at this cost? Last month, I saw a total of 1,600 patients. So how many working days? These many days. What is my total cost of running the clinic? That is my cost of seeing per patient. I am not even taking the cost of my intelligence. Do you know how much you earn per patient? We always decide our charges based on the neighbors or the competitors. Do you know how much you spend every month? Especially if you are in private practice, you are not in a salaried job. Do you know how much you spend every month for practice and for your house? Personal expenses, your clothes, your shoes, family expenses, or dependent expenses. Do you know what's your bank account balance? How much money is lying in your bank? Most doctors I ask, no, they don't even know how much money is lying in their pocket on a daily or weekly basis. Have your checks bounced? Has it ever happened? Whatever reason, there was no money or you forgot that money is to be put there. Or is there too much money in the bank not earning interest because your savings account gives you very little interest? You have more money than you need, then it should be put up for better returns. Honestly, most of us do not know how much we spend every month. Or many of us may not even know how much we earn per month if we are in private practice. Budget. How do we start budgeting our colleagues who are in private practice? Zero-based budgeting, an approach that requires planning from scratch every month. First of every month, I decide all that money I saved last month will not be used for expenses this month. I have to earn from day one to spend money. It's a great way to prioritize essential cost. Because in first week, you have to pay salaries. Do it from the income of that month only. Zero-based budgeting, I start with a zero first of every month, allows you to see where you can save some money. I'm not saying being miser. Limit credit. In 1988, I realized I have a credit of 45,000 and all those patients had stopped coming to me. And this was the time when our charges were 5 rupees per day medicine. We don't even calculate how much money we owe. People owe us and we don't get that money and that patient leaves you. Person feels bad, let him feel bad. If somebody is coming to you because you give credit, then you better not have that patient. And if you are in a habit of spending money on credit card, please stop that also. If you don't have money in your wallet, don't buy anything. Pleasures and necessities. What is luxury? What is required? How much, whatever money you may make 10 lakhs a month. Doesn't mean you can waste money. Evaluating what extras really add to your life and eliminating wasteful expenditure. Watch your investment. As we talk to a consultant, our friend for our health, talk to a financial advisor, not one of your patients. Nobody from your practice should know how much money you have. An independent financial advisor. So you should understand where to save, where not to save. Move your money to low risk investment whenever you can. Low interest is okay if the risk is nil or minimal. If somebody is guaranteeing you high returns, don't believe. Can we guarantee cure? If you have time, do some research. Otherwise, get an advice from financial advisor. Think twice before a luxury spend. car. Do I need a luxury car? I have to. The purpose of a car is going from one place to another. Television. Do I need a 100-centimeter television for my house or my clinic? Phone. If I have my ambition of buying an iPhone, I may save money and buy. But every time a new edition comes, sorry, not for me. Don't panic. You have money somewhere, the money get lost. Or you suddenly find that you have no money to pay your EMI. Don't panic. Risk comes from not knowing what you are doing, and discuss every economic financial situation very well before you make decisions. So, in November 2023, Amara Health is launching a website called IndianDoctorsPlatform.com. This, in addition to CME, will also provide content, webinars, and advice on financial literacy for those who are interested. And the 150th webinar next week will be legal and medico-legal implications of a medical cause of death certificate that we issue, MCOD, because many of us are still making big mistakes and are likely to come into the clutches of the municipal corporation. Drug for systolic hypertension. Dr. Smita, systolic hypertension is very common in elderly people. You may consider a calcium channel blocker. What is BP cutoff level in Indians? How long to wait with lifestyle modification before starting medicine? See, since today we were just talking on the new concept of BP measurement, when you have a patient who's diagnosed of blood pressure, you have to do a thorough profile of that patient. Sugar, fasting sugar, HbA1c, lipid profile, creatinine, uric acid. So that you know that what target organs are affected, including an ECG, even if asymptomatic. Then if you are in a stage of pre-hypertension or early first stage hypertension, and you feel the patient has a hope of controlling by better life. Like, if I have a patient who says, I don't take salt, I don't take fried, I exercise regularly, then I don't want to wait for lifestyle management to bring it down. I give medicine immediately. If the patient has a poor lifestyle, I give him time. I maybe give him a month. In 1 month, it may not normalize, but it should show a trend of improvement. Dr. Nirmala Singh, high systolic and normal or low diastolic pressure, which drug to prescribe? Again, calcium channel blockers. See, low diastolic, I myself have a diastolic of 68 to 70. It doesn't cause any problems. When we should advise ambulatory BP monitoring? If you feel a patient is having a lot of fluctuations, you should advise for ambulatory BP monitoring. Amlodipine better or cilnidipine? Definitely cilnidipine is better. Which is better, indapamide or clothianidone? Indapamide has less side effect profile, but it does, both of them have a higher risk of hyponatremia and electrolyte disturbances. Something like low BP in a routine OPD? No. Any particular model of electronic BP machine? I generally use diamond only, and I recommend that only. Accuracy of wrist monitor, I would not like to depend on that. 24 ambulatory BP gold standard, and what are indications? See, nothing is gold standard. I had a patient who had ambulatory sugar monitoring, but we realized that sugars were haywire. How to treat hypertension, Dr. Anju? That's a very separate webinar on itself. Patient getting pedal edema can get due to calcium channel blockers, or if there is edema, water retention, or it may not be related to hypertension. It may be just varicose veins. So please reliable. Please rule out whatever is the diagnosis. Reliability of digital BP monitoring by patient at home. Yes, as I said, follow the instruction of the machine and 10-minute resting. Thank you very much. See you next week.